Thanks for this very nice introduction. Yes, so I'm not a big expert in STI, but quite a bit in antimicrobial resistance, and we had the chance to test the total solution from SpeeDx, and I will present you our results in this presentation. So a few words, but now before me you get three different presentations about that, so I will go quickly. And as you can see that here we will be interested by chlamydia trachomatis, gonorrhea, and also trichomonas vaginalis, and I will speak about some clinical concerns, especially for chlamydia trachomatis with the lymphogranuloma venereum, LGV especially, and also I will speak about the problem of antimicrobial resistance and GC, especially about fluoroquinolone, macrolides, and third generation cephalosporins such as ceftriaxone. And as you saw before, there are also an emerging problem of resistance with Mycoplasma genitalium, especially for macrolides and fluoroquinolone as well. And in this context, we need new rapid molecular tools to guide therapy and limit AMR spread. So the aims of the study were to evaluate the performances of this total STI testing solution from SpeeDx with two steps. The first step was to screen using a simultaneous detection of CT, NG, MG, and TB, and for positive samples for chlamydia trachomatis, for example, the second step was to detect LGV cells. For NG positive samples, the second step was to detect mutations related with fluoroquinolone resistance, and for MG positive samples, the second step was to identify both mutations responsible for macrolide and fluoroquinolone resistance. And of course, the second aim was to assess the prevalence of these pathogens and AMR profiles in REN in our setting. So we used the different kits from SpeeDx, which utilize SpeeDx technology with Plexime and PlexPrime technology. The screening assay was a single well multiplex qPCR targeting both CT, NG, MG, and TB. This is a beta test, and it is compatible with the LightCycler 482 instrument from Roche. And because we have that at the lab, so we tested all the samples here. And here we have the cutoff for positive results. And for the second step, for specific assays, we use different assays. The first one was a CTLG kit, also a beta test, also compatible with the LC482 instrument from Roche, and it corresponds to a single well duplex qPCR detecting LGV CT cells. We used the Resistant Plus GC kit that my colleague presented just before me for the detection of wild type and mutant JAR-A markers. We used also the Resistant Plus MG kit that the first speaker presented, that simultaneously detects both MG and also the 5 main 20S RNA mutations responsible for macrolide resistance, and also the last kit, beta test, MG plus PARC kit, the 2-well multiplex qPCR for the detection of the main mutations associated with fluoroquinolone resistance. So we use the flow solution from Roche, especially we use for DNA extraction Magna Pure 96, and we use also the Lycycler 482. And we tested the DNA extracts already extracted in our lab from consecutive clinical samples received at our setting in France, in Rennes, in Brittany. And these clinical samples were collected from male and female patients between October 2018 and March 2019. Concerning the clinical samples, we tested 1,724 clinical samples from 1,489 patients, and we tested all these samples for the 4 bugs as spoke before. The different types of clinical samples were, for half of them, vaginal, cervical, and swabs, and for 36% corresponded to urinary samples. And most of these samples corresponding to only one sample per patient, and some patients had some multiple samples. I'm sorry. So what are the results for screening? For CT first, we got 86 positive results corresponding to 81 patients, corresponding to a prevalence of CT in our population of 5.4%. About NG, we got 35 positive results corresponding to 27 patients and corresponding then to a prevalence of 1.8%. For MG, we got 43 positive results corresponding to 35 patients and a prevalence of 2.4%. And finally, for TV, we got only 8 positive results corresponding to 7 patients and a low prevalence of 0.5%. We got here only 4 invalid results due to the presence of PCR inhibitors, and we got also patients co-infected with 2 pathogens, especially a patient with both CT and MG, and 5 patients with CT and MG. And we compared these prevalence numbers with the very recent study from France, which investigated more than 2,600 consecutive urogenital specimens from 16 French university hospitals, and as you can see here, our prevalence were quite lower than the previously described in France. But as you can see, as you can know, there are variable prevalences depending on the sites. And now, what about the results for the second step assays? First, for LGV detection, as you can see here, only one LGV isolate was detected, which was confirmed by the National Reference Center in Bordeaux, and corresponding to a prevalence of LGV sera of 1.4%. You can see also in this table that we get some problem due to an absence of detection of CT and for 5 samples. And also we had also 6 samples with insufficient volume, so it was not possible to redo analysis. So if we want to think about the molecular guided therapy for CT, if a patient had a CT infection, and if it is an uncomplicated or urogenital infection, you can use azithromycin or doxycycline. Okay, but if you use azithromycin, you can have also some selective pressure for the emergent resistance in other microorganisms. And if you have anorectal infections, if you have the chance to have the molecular assay, if you are LGV negative, you can use doxycycline for 7 days. But if you have LGV serovar, you need to extend your treatment during a 21-day course. What about the result for fluorokinase resistance detection in NG? As you can see here, we got some resistant, ciprofloxacin resistant bacteria with a prevalence of ciprofloxacin resistance of 43.5%. It's quite high, but is similar that the prevalence which has been described in France is 2017, which was 41.7%. We had two different undetermined results, maybe corresponding to other mutations. We had also 2 samples with negative results for NG detection, which could correspond to DNA degradation, or maybe because you have some differences between the screening assay and the specific assay, especially maybe the screening test could be more sensitive. And the same, if we want to use a molecular guided therapy, resistance guided therapy for NG, if you have an uncomplicated NG infection, but you don't have any molecular testing, so you will use ceftriaxone plus or minus azithromycin, but the problem will be the same with the selective pressure due to azithromycin, especially for the emergent resistance in the MG, but also in NG. And if you have a molecular testing to do that, it's possible, as Kate said just before, to use fluoroquinolone for susceptible strain, especially ciprofloxacin as single dose. And if you are in the presence of fluoroquinolone resistant bacteria, you must use ceftriaxone, also as a single dose. So meaning that if you have this molecular testing at your disposal, you can spare for half patient the use of ceftriaxone and the risk of to have also the ceftriaxone degree susceptibility emergence. And finally, for the MG, first results for macrolide resistance. As you can see here, we have a prevalence of macrolide resistance about 23%, which is lower than the 43 prevalence described in France in 2017, meaning that you have the prevalence of macrolide resistance is variable depending on the hospital in France. And we have also 10 samples which were negative for MG detection in this second test, meaning maybe we had some DNA degradation, or probably the performances between the screening test and the specific test were quite different. For fluoroquinolone resistance in MG, you can say that here the prevalence of fluoroquinolone resistance were around 10%, quite similar to the 7.5% in France in 2017. And we had also the same negative result for MG detection for 10 samples previously. So if we want to think about the resistant guided therapy for MG in the presence of uncomplicated MG infection, and as the very recent Australian guidelines recommend, we can use doxycycline first during 7 days. And as we said just before, that the clinical cure rate is not quite high, only 30 or 40% with this type of treatment, but you don't have any acquired resistance to tetracycline in MG. And thanks to this treatment, you can have a significant decrease in bacterial load, which could decrease the risk of resistance emergence. And during this 7-day period, you can have the time to do molecular testing, and you can have a sequential treatment thanks to that. And if you have a macrolide susceptible strain, you can use azithromycin after the doxycycline therapy. If you have a macrolide resistant and fluoroquinolone susceptible strain, you can use moxifloxacin. And if you have macrolide, both macrolide and fluoroquinolone resistance, you must use pristinamycin, but as Jürgen said, that pristinamycin is not available in many countries, but in France we have this. So, as a conclusion, I will say that molecular testing for AMR detection in STI bacterial pathogen, you have different benefits. First, you can prescribe an individualized treatment for better clinical cure, and with the reducing of AMR selection risk, you can decrease the antibiotic selective pressure and also the risk of AMR spread by sparing critical antibiotics, especially azithromycin, fluoroquinolones, and also ceftriaxone, because now we have some ceftriaxone resistant GCs. And also this molecular testing will allow to enhance the AMR surveillance. But limit is always the cost, and how you can integrate your this test in your lab workflow. It depends on your lab. And finally, I would like to acknowledge my residents in my lab, Zaida and Christopher, who did all this beautiful work with, as we can see, that more than 100 and 700 samples, and also Dr. Gabriel Auger, just here, and also SpeeDx people, especially Simon and Terry. Thanks a lot for your attention.